Good morning, everybody. Thank you so much, everyone, for joining us. We've got a full audience here on Zoom. I'm loving it. I am Brooke Thomas. I'm your CME specialist with Community Hospital, and today we have our very own Dr. John Rawlings presenting to us on simple fractures. A couple of housekeeping items before we start. If you have any questions for Dr. Rawlings, please add those to the chat. We will answer those throughout the presentation. Dr. Rawlings does not have any disclosures. Community Hospital designates this program for a maximum of one AOA Category 1A credits and will report CME and specialty credits commensurate with the extent of the physician's participation in this activity. Community Hospital also designates this live activity for a maximum of one AMA PRA Category 1 credits. Category 1 credits, physicians should claim only the credit commensurate with the extent of their participation in the activity. After completing his undergraduate degree at Brigham Young University, Dr. Rawlings joined the Army to help pay for medical school at the University of Southern California. He was active duty during his 5 years of residency at Madigan Army Medical Center, and he then was stationed at Fort Stewart, Georgia, where he served as a general orthopedic surgeon for 4 years. While there, he had the opportunity to serve as the chair of orthopedics, and he was the team surgeon for the 160th Special Operations Aviation Regiment known as SOAR. He also deployed to Afghanistan with a Special Forces group in 2018, where he proudly helped many injured American and Afghan soldiers and civilians. He was honorably discharged from the Army in 2021 and decided to do an extra year of subspecialty training at the nationally acclaimed Southern California Orthopedic Institute with several world-renowned arthroscopy surgeons as his mentors. Since moving to Grand Junction in 2022, Dr. Rawlings has focused his practice on comprehensive shoulder, elbow, and knee surgery, as well as general fracture care. He is a team surgeon for all of the sports teams at Colorado Mesa University, Grand Junction and Central High Schools, and the Grand Junction Jackalopes. Dr. Rawlings and his family fell in love with Grand Junction immediately upon their arrival in 2022. He loves spending time with his wife and 4 children as often as he can. Whether with family or friends, he also enjoys participating in all kinds of sports and outdoor activities: soccer, volleyball, football, skiing, snowboarding, running, hiking, biking. It's all good. Okay, Dr. Rawlings, the floor is yours. Thank you.
Thank you, Brooke. I appreciate it. First, I just wanted to, I know Brooke already said this, but encourage you to ask any questions along the way. We can stop between each kind of set of fractures if you have any questions regarding them. Um, so we'll get started here. Brooke already kind of did my whole introduction, so I'll skip through this one. Um, And one thing I wanted to add, many of us, most of the orthopedic surgeons do take care of fractures. I do take care of a large majority of fractures that will come in, with the exception of the pelvis and a few complex periarticular fractures. So first to introduce like simple fractures, the whole idea for this presentation was to try to help primary care providers just feel a little bit more comfortable with treating certain types of fractures. And many of them can be dealt with by primary care providers totally appropriately, especially those that have a very low likelihood for ever needing surgery. I will add, it's never wrong to refer any fracture to an orthopedic specialist if you ever feel uncomfortable at all. But also, I'll I put my contact information at the very end of these slides. But if there's ever a time any of you have any questions about a fracture, about whether you could deal with it on your own, if you would like to, you can feel free to reach out to me either by text or email. I'm more than happy to answer any of those questions. So first, general principles for fractures that potentially do not need a referral that you could treat yourself are one, a non-displaced fracture that's a single bone and it's not associated with a dislocation or subluxation. So of course, on this slide, this is not an example of that. There are two bones involved, and the ankle is actively dislocated. So one of the most common things that you might come across is something that's an occult fracture. Generally speaking, these almost always can be treated without surgery. So, and the most common incidence of this is in the elbow, and especially in pediatric fractures. So what will happen essentially, and you can see on this slide, this red arrow, it's pointing to this decreased density, which is really hematoma inside of the elbow is what's creating that. So you can see it on the front and frequently on the back as well. And that just basically indicates that there's a hematoma inside of, there's a hemarthrosis. So just blood inside of the joint. And when a radiologist sees that, then they say there may be an occult fracture. And in that case, all we need to do is get a repeat X-ray 10 to 14 days later. And if we get another one too soon, like just a week later, a lot of times that's too soon, then you won't necessarily see the fracture. And the idea behind getting a repeat X-ray a couple of weeks later is that the first part of fracture healing is actually osteolysis at the fracture site. So the fracture will become visible about a couple weeks later. And in the very young patients, really under 6 years old, especially for younger, sometimes you will start to see healing that early. So you'll see a little bit of a what we call fracture callus starting to form. And that's even if you don't see a fracture line, you can be sure that there was a fracture there. Um, Again, if you have any questions along the way, please put them forward and we can answer those as we go. Um, Next set of fractures I wanted to talk about is clavicle fractures. Many of these do not need a referral. So any simple patterns, just a simple fracture without any significant comminution, less than 100% displaced. They're not really shortened at all, and non-overhead athlete. For any overhead athlete, 100% of the time I would suggest referring these. And the reason for that is that it just deserves a conversation with an orthopedic surgeon so that they can decide whether they think they need it fixed. I mean, if it was like this fracture that's shown, I don't care who it is, I'm never going to treat that operatively. But nevertheless, I think it's just a wise thing to do for any overhead athletes. Also, just for informational purposes, I'm way less aggressive. I mean, generally speaking, almost anyone will be less aggressive with surgery in the skeletally immature or low demand elderly patients. So, I mean, for example, if I have a 14-year-old who has a clavicle fracture, even if it's greater than 100% displaced and some comminution, the likelihood of me ever fixing that is almost zero, just because they're going to heal really, really well from it. That being said, you know, if they've reached skeletal maturity, if they're 16, 17, 18, even though it may heal really well, if it's shortened and displaced, then they may not get quite as good function long term, depending on the displacement and shortening. So, again, that's just something I think deserves a conversation with an orthopedic surgeon. The last thing to be aware of is distal clavicle fractures. If they're truly non-displaced, then I would definitely repeat an X-ray 1 to 2 weeks later. The reason for that is that distal clavicle fractures are frequently associated with tears of ligaments near the acromioclavicular joint. And so you just have to be really careful of those to make sure that they stay non-displaced. Otherwise, they're more likely to need surgery. So treatment for clavicle fractures, generally you'll put them in a sling for about 4 weeks. You can progress to less than 5 pounds weight bearing until no longer tender tube palpation and full range of motion after those 4 weeks. Recheck the X-rays again on skeletally mature individuals at about 6 to 8 weeks after injury. When it's always okay to repeat X-rays. For the really young patients in particular, and here I said skeletally immature. If they're getting close to skeletal maturity, in their teenage years, then I would still get repeat X-rays. But especially in these patients who come in, 2-year-olds, they have a clavicle fracture. Frankly, most of the time, 3 days later, they start feeling great. You don't actually even need another X-ray. They're going to be fine. There's almost zero chance that that is not going to heal perfectly well. Um, once they're no longer tender to palpation and they have full range motion, then you can slowly progress their weight bearing as tolerated. Usually that's around 8 weeks or so, but sometimes earlier if they're younger. And I really only refer them to physical therapy if they're struggling with motion, which is pretty rare with clavicle fracture. Are there any questions thus far?
I'm not seeing anything so far. If you
All
do have
right,
a question, please add that to the chat. Thank you.
sounds good. So next topic is distal radius fractures. Those fractures that don't need a referral are simple buccal fractures, as can see in these X-rays. Where, I mean, what a buccal fracture is basically one side of the bone is kind of pooched out right there. The other side is just a little bit bent, but there's not actually a crack through the bone. So I'll describe it kind of like cardboard. If you have a thick piece of cardboard and you bend it just a little bit, one side will pooch out just a little bit, the other will bend, but it doesn't actually break through the cardboard. And skeletally immature individuals' bones are more elastic and less brittle than adult bones, and so this can happen. They're very, very stable fractures in general. One thing I will warn is that if you do see a fracture line going across it, even though there's pooching, if there's a fracture line, then that is a less stable fracture. So it doesn't necessarily mean it has to be referred, but you just need to follow it more closely. So anyway, you have this buccal fracture not really displaced, and there's no movement on X-rays 1 to 2 weeks later. If it's a true buccal like this without a fracture line, then it's not going to move. But if there is a fracture line, then you want to really make sure you get X-rays 1 to 2 weeks later to make sure it hasn't moved. And if that's the case, then you're totally fine still. Also, you'll need to be aware of radial styloid fractures. Actually, on this next slide, I have a picture of that. And it can be associated with scapholunate disruption. And so if you look at this fracture pattern, it's a radial styloid fracture. What happens is the energy of the fracture goes straight through here and then goes through the scapholunate ligament. And I just mentioned this because the fracture itself is non-displaced, but there's a space between these two bones. And if there's a space between these two bones, then that's a big problem, and it can lead to arthritis down the line if that ligament is not reconstructed. So reconstructed or repaired. So this is one thing where you have to be a little bit careful of it. And if there's a radius styloid fracture, you're nervous about it. You don't feel great about looking at the X-rays. That's totally fine. Referral is always fine, as I've said before. But it's one thing where the fracture itself can look totally benign, but then the patient actually has a problem that needs surgery. Otherwise, fractures that do not enter the joint in this area, if they're not displaced, it's really not a big deal. Treatment for it is generally a short arm cast for buccal non-displaced fractures, 4 weeks for pediatric patients, and 6 weeks for adults. For adults in particular, I would recommend adding vitamin C to decrease the chance of getting complex regional pain syndrome. We actually have several studies that have shown there's a significantly reduced chance of that. So I generally give that to patients, 500 milligrams daily for 50 days. And then once they come out of the cast, I usually do send them to therapy. It's helpful for a few reasons. Sometimes people will have residual swelling in their fingers. just from being casted for that long. And so it can help with the swelling in the fingers, but also help with getting back the wrist range of motion. Also, I generally will give patients a cock-up wrist brace for about 1 month afterwards, just to be worn during higher risk activities. Um, if it's a older, frail patient, then I like it just to give extra protection in case they have another fall. Presumably, the injury happened from a fall in the first place. For younger patients, I'll have them do it when they're being super active. Kids, if they're out on the playground playing a sport, anything like that, then I'll have them wear a wrist brace for another month afterwards. Also, generally speaking, with most fractures, I'll get a repeat x-ray 1 to 2 weeks afterwards, make sure it hasn't moved, and then again one more time before you finish treatment and say, hey, you're good to go.
Dr. Shelton, or sorry, I've got a couple emails going.
No problem, please.
Dr. Rawlings. I'm sorry. So we have from Dr. Ottaway from your previous slide, not called Torus fracture anymore.
So it is. It's the same thing. So you can both. They mean the exact same thing. So whether someone says buccal fracture or Torus fracture, it's all the same. I mean, the ICD-10 it says Torus. So um, for whatever reason, it doesn't usually come up as buccal fracture, but they're synonymous.
Good deal. And then one more question from Sarah Scott, vitamin C or D?
C. Did I say D?
I think you said C, but she just
Yeah,
wanted.
so vitamin C is specific for complex regional pain syndrome. Vitamin D, that's an excellent thing to bring up. I'm a huge fan of vitamin D, particularly for patients who have insufficiency type fractures. Most people, as all of you may know, are vitamin D deficient in our day and age. So adding vitamin D is never wrong. Um, and usually, if it's to try to increase fracture healing, I'll recommend 2,000 IUs daily, just during the healing process. But vitamin C in particular, I mean, for younger patients, it probably doesn't matter in terms of the vitamin D, but for vitamin C, just every once in a while you have a patient, and it's not a huge proportion of patients by any means, but after they come out of their cast, they'll have all this, hypersensitivity and all these problems with complex regional pain syndrome, swelling and increased blood to the area, all that kind of stuff, and vitamin C has been shown to decrease that. So it's specifically vitamin C for CRPS, but vitamin D is not wrong by any means.
Thank you. No more questions.
Perfect. So next is olecranon fractures. Those that do not need a referral are those that are non-displaced, that you need to make sure that they have an intact elbow extension. So, they're able to actively extend their elbow against gravity. And I say that specifically because if their arm's down on their side and they can let gravity do it, that's not the same as actively extending it. And then finally, it's non-displaced. They're able to actively extend. You get x-rays another 1 to 2 weeks later, and there's no movement, then you're fine to continue to treat it non-operatively. I will mention that, this particular fracture, this would be a great one to treat non-operatively. I would treat it non-operatively basically 100% of the time. At 2 weeks later, I'd mentioned before for occult fractures, the first step in fracture healing is osteolysis. Basically, the bone, the osteoclasts, the bone cells that kind of clean stuff up, they come in and they clean up the small little fragments of bone in there. And at 2 weeks, the fracture line may actually look a little bit bigger, but as long as the overall alignment and displacement is unchanged, then you can continue to treat it non-operatively. These ones, though, frequently need to be followed for about 3 months or more to see full healing. And that's just because they are articular fractures. So the fracture goes into the joint. Any fracture that goes into the joint takes longer to heal. And the reason for that is because the joint fluid itself actually slows down healing. Um, and so you just have to watch it longer. I'm just letting you all know so that if you do choose to treat one of these, which is totally appropriate to do so, that you may be sitting there and you're like, man, it's 2 months later and I don't see any healing. What's going on? That's not unusual, and you don't need to get too worked up about it, just as long as it continues to not be any displaced at all. So treatment for these, splint them for just 1 to 2 weeks, then begin range of motion, and they can continue a sling for comfort after that. But the key is to avoid active extension. I know in the clinic I told you to test them for active extension initially, but outside of when they are showing you that they can actively extend, I don't want them to actively extend their elbow. So it's okay when their arm is down by the side to have them do elbow extension, but just not actively because you don't want the triceps pulling on that fracture and risking it getting displaced. Um, and that's for about 4 weeks. I tend to tell them not to push up out of a chair until healed on x-ray, which is frequently about 3 months. So that's something that can be really hard because 6 to 8 weeks later, they start feeling really good. You just need to really remind them, hey, don't push up out of a chair. We really want to make sure this heals without displacing anymore. In general, most things, if people are paying attention to their bodies, they're not going to do something that's going to make it worse. But the problem is you're pushing up out of a chair, you stumble a little bit as you're getting up, especially for more elderly patients, and all of a sudden it goes from a controlled movement to something that's not controlled and could actually cause some damage. So that's where I just say just avoid it altogether. Generally, I'll say at about 6 weeks, they can start lifting up to 5 pounds, but that's just with elbow flexion. And so if you think about it, lifting 5 pounds with elbow flexion, it's not going to be putting stress on that on the fracture site. Of course, you don't want them doing active extension while lifting 5 pounds, but if their elbow's to their side and they're just flexing their elbow, then that's totally fine. I always do get repeat x-rays 1 to 2 weeks later to make sure there is no displacement. And then again at 6 and 12 weeks to make sure it's healing appropriately. And similar to the distal radius fractures, the clavicle fractures, I really only do physical therapy if they're struggling with motion. With elbow fractures in general, this is a little bit more likely. Elbows just tend to get stiff a little bit more easily, but I will usually hold off making that decision until at least 6 weeks, evaluate how their motion is. If their motion is really terrible, they're like 30 degrees short of full extension, then I'll put in the order right then, even though they may not start until another month later. Just because, at least in the Valley right now, if you put in an order for physical therapy, they're not going to get seen for at least 4 weeks. So, something to think about with that. All right, so the next one is radial head fractures. Similar to others, times when you don't need a referral is when it's non-displaced and you have intact forearm supination and pronation, as well as elbow flexion extension with no hard block to motion. So that sometimes can be a little bit tricky to say, and especially right when you see them. If you see them, the day of injury or a couple days after, they're just going to be really sore, and so they're not going to want to move it very much. But it's just something to think about. So when they come back a couple weeks later and you get a repeat X-ray, then also just check their motion again and uh, try to figure out. I mean, if they have full pronation, supination, and there's no crepitus, and they feel good about it, and they're able to move their elbow, and it may not be completely full extension because that takes a while to get back. But if it feels like it's kind of a spongy endpoint, then they're going to be just fine. They'll be able to regain all of that. But similar to the olecranon fracture, because it is an articular fracture that goes into the joint, it does take longer to see the healing on x-rays. So similarly, you'll need to wait about 3 months before you really see good healing a lot of the time. So on these, the treatment is a little bit different. You sling them just for 2 to 3 days. The biggest problem with this fracture is actually stiffness afterwards. So you want to begin early range of motion just after 2 to 3 days, and it's active and active assisted range of motion. I don't have them do passive motion. I think that can, if you allow a physical therapist to do passive motion, then um, sometimes they'll try to push it beyond what's painful. Whereas if it's active or active assisted, it's a more controlled environment because they're doing it themselves and they're going to limit themselves based upon pain. I do usually allow them to lift about 5 pounds after 6 weeks, as long as that's not painful. But before that, it's non-weight bearing. And then similarly to many of the other fractures, repeat x-rays 1 to 2 weeks later, and then at 6 and 12 weeks. And again, PT if struggling with motion, and I'll really evaluate that at about 6 weeks later um, to make sure that they're progressing well. If they're just, 5 or so degrees away from full extension, they're going to do great and not going to have any problems. This X-ray right here is actually an example of a displaced fracture. It may seem kind of subtle compared to this other one. I mean, this one, it's pretty non-displaced, especially when you look over here. These kind of line up, whereas this one over here, it clearly fell off, and that one is unfortunately going to most likely going to be a problem and needs surgery, and that would be one that I get a CT scan for and almost for sure operate on. So just a subtle difference, but I think you can see there's a clear step off, whereas the other one was more of just a small gap. Next is patella fractures. So those that don't need a referral are those that have a vertical pattern, almost never need surgery at all because the extensor mechanism will be intact. You do need to check that always, though, so make sure that they can actively extend their knee against gravity. There's also non-displaced transverse fractures, so that I have a picture of that here in this next slide. So vertical fractures or non-displaced transverse fractures, but you just need to really make sure that they can actively extend their knee to a full extension or about 2 to 3 degrees short of where their passive extension is. As long as they can do that, they're going to be totally fine. If they have if they have 10, 15 degree extensor lag, then I would refer that every time. It doesn't necessarily mean we'll definitely operate on it, but there's a higher risk for it and just needs close follow-up, really close follow-up to determine whether surgery is going to need to be performed. Of course, if it's displaced, when they're displaced, it's pretty obvious. They're like in frequently different ballparks, and the patient can't extend their knee at all, can't hold a straight leg raise, nothing, and those obviously need surgery. But these other ones, may look, yes, there's a little bit gap on this side, but the articular side is still intact. And when there's this little displacement, then that means that the soft tissues, the extensor mechanism is still intact across it, and that's what's kind of holding everything together. And as long as it's being held together by the extensor mechanism, then it'll be totally fine for non-operative treatment. So I actually let them bear weight with these, but they'll be in a knee immobilizer for 6 weeks. So weight bearing is tolerated 6 weeks. In a knee immobilizer, they come out of the knee immobilizer just for hygiene purposes and for range of motion. So in these, if the extension mechanism is intact, it's actually totally fine to work on range of motion. But it's again active and active assisted, not non-passive range of motion until 6 weeks, just to make sure that they don't push it past that point that is safe. And repeat x-rays about 6 weeks afterwards before advancing out of the knee immobilizer. Make sure that you do see some healing. Range of motion for articular fractures, I don't think I mentioned this before, but range of motion actually helps the healing process. So, I'd mentioned that the joint fluid slows down healing, but the motion actually stimulates healing. So it's one of the ways you can fight against the joint fluid from slowing it down. All right. Next topic is ankle fractures. So those that do not require a referral are non-displaced medial malleolus fractures. I don't have a picture of one of those right here, but something over here, medial malleolus fracture. And then Weber A. So this is A, where it's below the level of the joint. We say it below the level of the plafond. So Weber A ankle fractures that are down here, or these little, just avulsion fractures, those definitely do not need referrals. But I'd be really careful about Weber B and Weber C fractures. Weber B fractures are frequently stable, but they require a stress x-ray to determine that. And the reason for that is because if um, if the ligaments are torn medially, so the deltoid ligament, if that's torn, then you have this break over here, and then you have some other ligaments between the bones that potentially are broken as well or are torn as well. And so a stress x-ray will reveal that because the talus will move a little bit laterally because it's not being held in place by those medial ligaments. And and you really only can tell that by a stress x-ray. Unfortunately, physical exam palpating the deltoid ligament has been shown to not be adequate. Probably one of the reasons for that is simply that they have so much pain on their lateral side that their medial side may or may not, um, uh, pain may or may not be painful. In addition, they could just have a sprain of their medial side, and that's painful. And so whether it's tender or not tender, it's just not a good indicator of whether it's stable or not. So you just really need to be aware of that. In general, I would say just if you just refer the B's and the C's, then you're going to be safe. With C fractures, if they are not from blunt trauma and they're above the level of the joint, then especially if it's a twisting motion, most of the time, actually, these will be unstable because the energy passes through the fracture, then down through the ligaments that are between the tibia and fibula, called the syndesmosis. If the syndesmosis is torn in addition to the fracture, which they commonly are in this type of fracture pattern, then it's operative every time. So you just have to be careful of those patterns. But anything that's either medial malleolus or below the level of the joint line can be treated without any surgery. So the treatment for these stable fractures, this one is actually an example of a non-stable fracture, Weber B non-stable fracture, before I get into treatment. And this is I'm not sure if this is a stress x-ray or not, but you can already tell because the space over here is much wider than the space between the bones here. And so the talus is protruding laterally, which just indicates that the deltoid ligament is torn and thus the whole ankle is unstable. So you need to stabilize it by fixing the fracture so that it'll be stuck inside and heal appropriately. So treatment for stable fractures is weight bearing is tolerated in a cam boot immediately. For medial malleolus fractures, I'll typically cast those. It's not inappropriate to put them in a cam boot, but I just don't have them bear weight. And small avulsion fractures can basically be treated like sprains, whether that's a boot or, frankly, a lace-up ankle brace, depending on how hard it is for them to bear weight. And repeat x-rays 1 to 2 weeks later to ensure no movement. If it's an avulsion fracture, you don't need to do that. A small avulsion fracture at the tip of the distal fibula, again, it's just like an ankle sprain. Don't worry about more x-rays, just treat it like an ankle sprain. Generally, for other fractures, you can transition them to a lace-up ankle brace at 6 to 8 weeks when they're non-tender to palpation at the fracture and x-rays start to show a little bit of healing. And then you begin physical therapy for range of motion strengthening and proprioceptive training. So that piece in particular, the proprioceptive training, I will almost always refer these patients to physical therapy just because the damage to their ligaments associated with fractures is almost just as important as the fracture, if not more important. And to decrease the likelihood of them breaking their ankle again or getting repeat ankle sprains after it, it's really important for them to actually get good proprioceptive training. So just with these, I would recommend send them to physical therapy so that they can really get their strength and proprioception, which that may be a term you don't hear a lot. So proprioception is really just your body's ability to know where in space the joint is. And you lose that when you have bad injuries to joints. So in particular, ankles are at increased risk of that. So I'll usually send those to physical therapy. All right. Any questions?
Not seeing any yet. We'll give it just a minute. If you have a question, please put that in the chat. We'll get that answered.
Yeah, so I know we kind of blew through things kind of quickly, but I think it's a good kind of base point for what fractures can be treated non-operatively, and especially if you in general, I mean, I think many primary care providers, which it's not wrong, it's totally fine. Almost any fracture they'll refer to orthopedics, and again, I have no problem with that. This presentation in no way is try to say, hey, stop sending me this lame stuff. That's not it at all. I'm more than happy to always see any fractures, but it's to try to empower you if you would like to feel a little bit more comfortable treating some of these. And I also want to encourage you, especially if you haven't done it before and you want to start to treat some of these, um, uh, any questions you have, whether it's a call, a text, an email, feel free to do that. I'm more than happy to answer questions. I have several primary care providers in the Valley that text me relatively frequently regarding questions about treating non-operative fractures, and I'm totally fine with that. Um, the other thing I would say is, I mean, one, it's this is less important, but by keeping those patients for yourselves, there is a nice financial thing. I mean, it's they're pretty easy to treat when they're non-displaced fractures. You can get a CPT code for
Won't you do?
can be nice to start to get comfortable with them and just keep them within your own group. But again, I have no problem treating every single one of these. So don't feel like we in orthopedics are like stop sending me this lame stuff because we're happy to treat them as well.
Excellent. Thank you, thank you, thank you. So we do have comments and questions coming in. Let me get
Okay.
it here. Okay. All right. From Dr. Arja, nice job. Thank you. From Terry Ahern, thanks. A great overview. From Kathleen Wilson, regarding PT, it typically takes about 8 weeks to get in. Will the PT triage to get some of these more immediate conditions in earlier?
So they do. They're pretty good. I mean, I may be biased a bit in in how I see that. And the reason is, in general, physical therapy, when they get a referral from an orthopedic surgeon, I realize that they're more likely to look at it closely. But they do try to look at anything that comes in and look at the condition and decide if it needs to be treated more acutely. But that being said, that's why I'll say for those fractures that you anticipate are gonna need physical therapy, putting in the order nice and early is never wrong. Sometimes, I mean, nowadays, because it's been getting so long, I've been putting in orders long before I know whether they'll need it, and then because it's easier to cancel it later. So, for fractures where you think that you may need it, it's totally fine. Put in the order right away. say, hey, this patient is going to require physical therapy at this time frame, whether it's 6 or 8 weeks later. And then if they end up doing great, then you can just have them cancel it. So, but I will say they do try to triage things more appropriately, but still within their system, even for us. So, like if I have a post-operative knee patient who had an ACL done, those really need to get into therapy as soon as possible. If I don't get the order in until they have surgery, they still won't see those patients for a couple weeks. That's still a lot faster. I realize that. But ideally, I would like those patients to be seen like days after their surgery, and they just don't have the capacity to do it. So I just mentioned that because they're constantly trying to triage things, but their capacity to even try to get stuff in earlier is still limited because they are so stacked across the valley. I mean, it's true across the valley. I mean, whether it's our physical therapists or others, um, and there are some of our physical therapists that are more stacked than others. But bottom line is, I would just recommend I mean, for something like a clavicle fracture, I wouldn't put it in. It's almost never going to need it. For those elbow occult fractures, don't need it. But for ankles, for distal radiuses, for elbow fractures, I would just put it in right away, just to give the physical therapist as much time as they need. And then when you see the patient back in about 6 weeks, if they're doing awesome, then you can just say, hey, you know what, you can call the therapist and cancel because I think you're going to be just fine.
Excellent. From Dr. Ottaway, thank you. Great talk. Every kid tore his fracture I've casted. The kid got sand in it within a week. And and then from Dr. Dan Sullivan, sorry if I missed it, but short highlight on finger fractures needing referral. Maybe it's its own talk.
Yeah, so finger fractures, I did not include those, but there are a lot of them that can be treated without surgery in general, if they're not displaced. The one tough thing about some finger fractures is just trying to determine if there's any rotation. If you have any concern about rotation for anything in the hand, always refer it. And so the way that you do that is you just have the patient close their hand, look at the other hand, make sure all the fingers line up the same on both hands. It can be tough because there's going to be a lot of swelling. So one of the fingers is going to be like that, but if it's sitting there and it looks like it's like bending one way or the other, then that absolutely needs a referral. Otherwise, splinting it with an alumifoam splint is totally appropriate. Um, if they're just the distal phalanx fractures, those almost never need anything. They don't even need a splint necessarily, just maybe for the first week or something, just for swelling purposes. The one thing I will say about finger fractures as well is you do want them to start moving relatively quickly. And I say that just for stable fractures, they're non-displaced. I would say splint them during higher risk activities, but after just a couple weeks, if they can move, then I'd want to start moving. Definitely after 4 weeks. Any finger fracture, 4 weeks is absolute max that I would want them immobilized. Most of them 3 weeks. And if they're distal phalanx fractures, 2 weeks only, max, maybe even just one if they're not too painful, just because stiffness is such a big issue. Thank you for bringing that up. I should maybe next time I give one of these talks, I'll add finger fractures. I was a little bit worried about time, but turned out we were okay.
Excellent. From Dr. Alkes, thanks. Great talk. Very useful information. From Kathleen Wilson, where in Grand Junction is the best place for a small PCP to order the slings and braces?
Good question. So I mean, we have a lot of them in house here, so I don't send a ton of stuff out. But in terms of outside things for general braces, slings, prostheses, all kinds of stuff, I'm actually been pretty happy with Evergreen. They are located just south of St. Mary's, but they're not associated directly with St. Mary's at all. But they're very responsive, seem to know what they're doing really well, and patients have given good feedback. So that's one I can say that is a good one, evergreen.
Thank you. And from Sarah Scott, how long does it take for a frozen shoulder to develop when someone does move the arm due to a fracture?
So frozen shoulder is actually really rare from a fracture for whatever reason. So if they have a proximal humerus fracture, most of the time it doesn't turn into frozen shoulder per se. They do get stiff, but it's a little bit different of a problem. And so, I mean, as weird as it is, frozen shoulder happens more commonly with uh, smaller injuries. And you know, just as a quick little thing with that. So, I mean, frozen shoulder itself, adhesive capsulitis, it's this weird process where their body, for whatever reason, starts inflammation of the joint capsule itself, and the joint capsule thickens and becomes super painful and essentially like scarred. It just gets super, super thick. And um, for whatever reason, it rarely happens with fractures. Um, of course, there are risk factors for it, you know, diabetes, thyroid problems, middle-aged woman. It's almost always a middle-aged woman. I say almost always. I recently had a man, but I mean, it's like I can't remember the exact numbers, but at least 95 to 5 women to men, and they're almost always middle aged. If they get if they get into their 60s or 70s, it's very rare to happen. But stiffness is different, and so I just want to make sure that's adhesive capsulitis or frozen shoulder is not exactly the same as any stiffness, and if it's around the shoulder, I mean, clavicle fractures virtually will never have problems with stiffness. Proximal humerus fractures almost always do, but it's a different type of a problem and one that it's not because of the capsule is thickening. It's usually because um, the fracture itself will cause this stiffness, and they may or may not regain all that motion back. But if it's a non-displaced fracture that you're treating, most likely they're going to regain it back, and you just start moving them about 6 weeks later, and they'll get it back. It just takes some time. Whereas, I mean, and by time I mean a few months. Frozen shoulder, you know, it can take 1.5 to 2 years if it's not treated soon. So anyway, does that answer the question? I hope it does. Please let me know if that didn't answer exactly what you were asking.
Sarah says, yes, it did. Thank you. From Kathleen Wilson, thank you for a great talk. From Sarah, thank you. It looks like those are all of the questions. So, Dr. Rawlings, thank you. Excellent job. Lots of great information for our PCPs out there. Want to wish everybody a very happy Thanksgiving next week. Powderhorn opens today, so go play,
Yeah,
go have some fun. And thank you, everybody, for joining us this morning. Have a great rest of your day. Thank you,
thank you.
Dr. Rawlings.